Thank you very much for your help and apologize for the delay in introducing the presentation. Good morning, everybody. I'm Miguel Muñoz on behalf, and I'm going to do this presentation on behalf of the HEFESTOS study group, which is one of the first international collaborative studies under the umbrella of the European General Practice Research Network. Okay. We carry out this study, I remember Malta at 2012, when we first presented as a 5 minutes, 1 slide presentation, and Angela helped us very much to make the final protocol. Because we thought that most evidence is about prognosis in primary healthcare heart failure patients when suffering a decompensation came from the hospital, and the determinants which condition the prognosis of these decompensations remained still unclear. Therefore, we designed a study aimed at developing and validating a predictive model based on clinical variables, above all, easy to be measured in general practice to predict short-term hospitalization and mortality at 30 days after the episode of decompensation, but the most important thing, in primary care setting. As a secondary objectives, we wanted to know the most common precipitants of decompensation, the clinical characteristics associated with, and the cumulative incidence of heart failure or mortality, which are going from now on telling event. Designed a multi-center prospective cohort study from September 2014 to December 2019, including patients diagnosed previously of heart failure and suffering from a clinical decompensation, and we follow this patient for 30 days after this episode. Patients should be attended in primary care, and we build two different cohorts, one for the derivation to create the predictive or to build the predictive model, which was developed in Spain, in Barcelona, and the other one to externally validate the results of the predictive model in 9 European countries. The primary endpoint was hospital admission and mortality at short term. We considered a set of predictive variables, which I'm going to explain along the presentation. Here you are the participant countries. We are very proud because we were able to include almost the differences in the whole Europe. We have patients coming from the North Scandinavian countries, Anglo-Saxon countries, South Europe, and Eastern countries. Patients must be 40 years or more, 45 years or more, diagnosed of heart failure, and of course presenting a decompensation and attended in primary care. We wanted to create a logistic regression models to predict and to explain the prognosis of this decompensation, and we further calibrated and discriminated the power of this model. Information came from the interview to the patients and relatives by clinical exploration, primary care medical records, and hospital discharge reports. And regarding ethics issues, the derivation core was approved by the Spanish, or in this case, the Catalan Clinical Ethics Committee, and every country must have approved the protocol in their respective countries. As a result, we are going first to present the derivation cohort, characteristics related to the probability of having an event. We can identify that chronic kidney disease, pulmonary diseases, dyslipidemia, and especially previous hospitalization in the year before to the inclusion as a consequence of heart failure episode were the most associated with the probability of having an event. We included 161 patients in the derivation cohort, and 390 presented an event, which is a very high percentage. Regarding clinical characteristics, we observed that the presentation of crackles, high heart rate, high respiratory rate, temperature, and a low oxygen saturation was related to a higher probability of being hospitalized or dying. Especially, you can look at the oxygen saturation 6 times more than the rest. Other clinical characteristics considered were paroxysmal nocturnal dyspnea, orthopnea, NYHA 3-4, worsening dyspnea, weight gain last week, and ankle edema. All these characteristics were also related to the highest probability of being hospitalized or dying. Then, finally, regarding the results of bivariate analysis, we built a multivariate model, including those the characteristics which showed statistical significance and clinical importance. And we can see that the fact of being woman, the fact of having been hospitalized, presenting crackles, heart rate, higher heart rate, paroxysmal nocturnal dyspnea, orthopnea, NYHA in 3-4, worsening dyspnea, and it is not, but the oxygen, the low oxygen saturation were the variables finally introduced in the predictive model. We tested the area under the curve, and we could observe that our predictive model estimated with a 0.81, which means a very high power regarding the predictive model. Here you are, the interval between observed and predicted, and which is very important is also the calibration plot. If you look at the line and you look at the dots, you can observe that it's almost the same, which means the calibration plot in the derivation cohort was very high. But once we got these results, we must validate them. We include 250 patients from the European cohort, from France, Hungary, Croatia, Bulgaria, Slovenia, Ireland, Germany, Italy, and Sweden, to have a wide picture among the European countries. We analyzed the differences between both populations, the derivation and validation, and we detected some differences regarding, for example, diabetes, coronary heart disease, atrial fibrillation, renal disease, smoking, COPD. We observed a higher respiratory rate and differences in systolic blood pressure. We considered lower than 90 because it's a validated criteria of severity in heart failure, and saturation oxygen. What that means? That means that populations were different in some points. Maybe, probably, some of the patients included in the European cohort had a more severe episode of decompensation, but the strength of these results is that we were able, as I am going to show to you in a few seconds, is that our model was also valid in different populations, not just different populations because of different health systems or different cultural or beliefs. No, even from different clinical situations. Here you are the area under the curve for the validation cohort, was also higher than 0.7. The calibration plot, which was also like the derivation cohort. And this is the queen of the presentation. Let me to show you. The final product of all this mega cohort study is this calculator. We have been able to build a calculator to predict the probability of being hospitalized or die in the 30 days before an episode of decompensation attended in primary care. For example, I know it's not elegant to ask for the age to a woman, but for example, Nicola, man, I think, age?
Sorry, 63.
63, okay, you are still young. You had not been hospitalized last year.
No.
You are a sportsman. You have no crackles, you have no paroxysmal, you are not orthopnea. You have in NYHA 1-2 because everybody had to suffer from heart failure, sorry. But the rest is very good. Therefore, your probability of being hospitalized and died in the next 30 days, congratulations, is very low. But 10 years from now, if you have been hospitalized, you present tachycardia, crackles, paroxysmal nocturnal dyspnea, orthopnea, of course, NYHA 3 or 4. You consult because you feel bad and you have a low oxygen saturation, your probability is almost 100%. I'm sorry, I'm really sorry. But you have to take care of yourself from now. Okay, we are going next trying to put these figures in a weighted table, which means, for example, 1 point for sex man, 2 points for age, and so on. We are still working on it because our intention is that this model will be useful in the bed of the patient. And in the bed of the patient in rural areas, you don't have any laptop to calculate there. No, it's easier to have a paper saying, okay, you are okay, you have to go to the hospital immediately, or not. I'm going to be able to treat you at home. Therefore, as a conclusion, the HEFESTOS-SCORE, based on clinical and demographical variables, above all, easily measurable in primary care, has demonstrated to be an useful tool to stratify the short-term hospitalization and mortality in patients attended because of heart failure decompensation. My congratulations to the rest of the colleagues, our acknowledgement to all of them. They have very hard work. They have had very hard work, and we hope that it could be the beginning of the great love. It is the inspiration to continue with clinical studies in primary care under the supervision of EGPRN. Thank you very much.